2 million of 2 million of Omani and
Yeah,
2
2.5
million
million.
of, yes.
We are almost reaching 5 million in total. I would say soon, maybe.
5 million.
Yes, 5 million in total.
Okay.
Yes, it's a big country, but small number of inhabitants finally. Yeah, because there are 2 million of Omani, and the other, I don't know. There are Indians, Bangladesh, for every world. Yes, in the world, but just 2 million of people. So the HPB surgeon, I don't know how many, but I think 20, no more, no? How many HPB
around 10, 11 maybe only.
Yes.
Yeah.
10, 11, wow.
Yes.
Yes, because finally there are just 3 main hospital. One is the Royal Hospital in Muscat, the Cancer Center, and the University Hospital.
Yeah, and
University Hospital, and we have also the military hospital.
Exactly.
Too, and another hospital in the south of Oman. No, exactly. I don't remember the name, but well, 4 or 5 hospital, but the main are the Royal Cancer Center and the University and the military too. Yes.
So good evening to all, and we are so happy to have Professor Matthew Dunadon with us here. He's a professor of surgery and the head of surgical oncology program at the University di Piedmont Oriental University Maggiore Hospital in Novara in Italy, which is, as I understood, not far away from Milan. He's a known figure in HPB surgery. He has so many publications, more than maybe 260, with so many citations, more than 7,000 citations, with an H index more than 45. So we are happy to have him today with us, speaking about the Perihilar cholangiocarcinoma and how to deal with it nowadays.
Thank you very much, Dr. Abdallah. Thank you, Professor Panaro, and everybody. I'm very happy to be with you this afternoon. Thank you for the invitation. I share my screen. Do you see the PowerPoint?
Yes.
Okay.
Yes.
So, surgery for perihilar cholangiocarcinoma. This will be the agenda of this short talk. A few slides about definitions and epidemiology. Some important points about diagnostic workup. The indication for surgery, the results of surgery, and then the conclusion. Today we talk about perihilar cholangio. We know that cholangio can be intrahepatic, mainly in the mass-forming form, more rare as a periductal or intraductal growing. But today we speak about the perihilar cholangio, which is about 50 and 60% of the cases. As we know, is a rare tumor. You can see here the incidence and the mortality for 100,000 people every year, and there is a kind of a wide range in the incidence due to the fact that this disease is associated with some specific risk factor in some geographic area of the world. In Italy, for example, as you can see here, the cases are not very frequent. I don't know in Oman, but I suppose that the cases are not common. And speaking about risk factors, I quote this paper, which is a nice review from the European Network of Cholangiocarcinoma. Generally speaking, we know that there are some specific risk factors, but to be honest, in the real world, most of the patients that we operate, they do not have, at least in Italy, specific risk factor for cholangiocarcinoma. And from a practical point of view, I like to say that it's useful to remember that some very rare biliary disease can be associated with the development of cholangio, as well as chronic hepatitis or cirrhosis, or more rare, not really in Italy and not really in Europe, but in some other geographical areas, some environmental toxins. It's interesting to note that in the last years, the definition of cholangiocarcinoma changed a little bit from the histological point of view. And this is in particular true for the intrahepatic because they divided the type of cholangio according to the size of the bile duct, identifying different subtypes. Not really for the extrahepatic bile duct tumor, but anyway, some differences has been recorded, has been described. And these are interesting, not only from the cultural standpoint, but also because this disease is associated with a very high heterogeneity in terms of a clinical outcome that can be, at least in part, explained considering the different subtypes. And similarly, it's important to remember that nowadays cholangiocarcinoma can be profiled for specific mutations. This slide shows some of the most common that can be identified. You see here, the rate of frequency of these mutations associated with cholangio. Again, to be honest, this is a little bit more important for the intrahepatic, but also for the cholangio, for the extrahepatic can be done. And it's important because this mutation can be, treated because we know that there are, molecular drugs that can be used today to treat these patients that have cholangio with mutations. So this is a very important point. Moving to something more surgical, I would say that we have with this disease some clinical issues, which are the late diagnosis, because sometimes the symptoms are very specific, and there is a corresponding associated low resectability rate, which depend by the local extension, vascular invasion, the presence of lymph node metastasis, the presence of small intrahepatic metastasis, and sometimes the presence of peritoneal disease. In this sense, it's important to understand which are the goals of the workup, because still today we face some difficulties also in big centers for this disease. And we need to confirm the presence of cancer and its resectability. We need to understand the extent of disease, in particular if there is a vascular involvement in the liver hilum, and in this sense the extent of the tumor and also the extent of the future liver remnant, as I will show later. And it's very important that all the workup, all the diagnostic workups, meaning CT scan, MRI, and so on, these imaging modalities should be done before the biliary drainage. This is very, very important because sometimes it's impossible because we see patients with drains placed in other institutions. But the problem, as we know, that once the drain are placed, the definition of the disease is very, very difficult. And in this sense, it's important, to try to understand where is the stenosis. If the stenosis is a benign or malignant, the craniocaudal extension of the lesions, the relationship within the vessel. If the patient has vascular abnormalities that sometimes can be used with with the intent to operate the patient, and of course the stage include the study of the presence of distant metastasis. All these items are those we ask to the radiologist to help us to understand the extent of the disease. We know that CT scan is a very good modality with high sensitivity and specificity, but we also know that MRI has the highest sensitivity and specificity, and also with the the sequence for the study of the biliary tree, we can have with the same examination both the study of the parenchyma, the study of the vascular structures, even if the definition on the vascular structures is a little bit inferior in comparison with the CT scan, but at the same time the study of the biliary involvement. I grew up in a group in which we believe a lot on the PET. I know that this is not something can be considered as a classical statement. I believe that the PET scan, the PET CT scan, has the potential benefit for distant lymph nodes and extrahepatic metastasis. I mean, as we know, the aim of the PET is not to study the bile duct or the lymph nodes close to the liver, rather to study and to rule out the presence of distant metastasis. By the way, if the PET scan cannot be done for different reasons, of course, a total body CT scan can be done with the same intent. And of course, the biliary tree should be studied. I will say a little more later. And depending, on the local resources and on the local use, we can ask to the radiologist to do a percutaneous approach, or rather to the endoscopic guys to make an ERCP. There is, of course, the advantage of make the pathological diagnosis, which sometimes remains anyway demanding, and to place a stent to mitigate the jaundice. There are important limitations on the workup for perihilar cholangio, the extent of the submucosal involvement, the periductal neural invasion, which is very common, the small nodal metastasis, the small hepatic metastasis, and also the peritoneal metastasis, which can be sometimes ruled out by performing an exploratory laparoscopy, which in fact should be, suggested. Nowadays, we are in the era of mini-invasive liver surgery performed by laparoscopy or even by the robotic systems. So the laparoscopic exploration per se can be seen as an old, point. By the way, for those who do not are so common in the mini-invasive liver surgery, or as me, I believe that for biliary tumors, mini-invasive liver surgery can be a little bit tricky, and so most of the cases are done with the laparotomy. Laparoscopic exploration with the laparoscopic ultrasound is useful to rule out not only the distant metastasis, meaning the small peritoneal metastasis, but also to study, with the laparoscopic ultrasound, the biliary stenosis, and to identify better the laterality of the disease to program the subsequent operation. And in an ideal world, this part of the procedure should be done as the first one, because of course, in case of peritoneal disease, the indication of liver surgery does not exist anymore. So this should be done as a first approach. Speaking about biliary drainage, I quote this paper because it's a large meta-analysis. These Chinese colleagues analyzed many different papers to try to understand which is the best option for biliary drainage in classical tumor. And rather than put on my presentations, all the forest plots, I summarize these statements. Of course, the biliary drainage is useful to mitigate the jaundice, because we know that differently to the pancreatic tumors, we cannot operate this patient with jaundice. So we need the drain to increase the safety of the hepatic resection. Of course, we are aware of the fact that biliary drainage is associated with an increased risk of infection. So as always, we need to balance, you know, the risk and the benefit of the placement of drains. But as a matter of fact, in most of the case, we put the drain. And speaking about PTBD or endoscopic biliary drainage, in this paper, they say that there is an increased risk of bleeding with the percutaneous, which is, you know, can be understood by the fact of, you know, of the liver. They say that there is an increased risk of pancreatitis by using the endoscopic drain. Speaking about infection rate, the rates can be, they are similar between the two drains. And speaking about jaundice control, probably it's better with the percutaneous drain. But how to decide? You know, to me, I'm used to have the radiologist. So generally speaking, I prefer the percutaneous biliary drain. Of course, this is a matter that depends by the local resources and the results. But more importantly to me is that in front of a patient with a jaundice and with a suspicious Klatskin tumor, early liver surgeon consultation should be the first thing to do, because the liver surgeon should be in charge to decide if the patient is resectable and which is the liver to resect and which is the liver to preserve, and in this sense, guide the placement of the drain. Because otherwise, if you leave the case to the endoscopic guys, generally speaking, they put the drain in the easy duct according to the procedure, which cannot be exactly the point in which you as a liver surgeon would like to have the drain. So speaking about resection, low resection rate, this is a kind of very common statement speaking about perihilar cholangio. But I quote this paper, which is not really recent, but it's probably one of the most largest experience published by the famous guy Najino and Imura from Nagoya in Japan, which are probably the best guys in the world for this disease. And if you look at the flow chart, they were able to resect the majority of patients that they had. So this means that, and as I will show you later, it's really important to understand that in particular for perihilar cholangio, the surgeon dictates the outcome, which means that we decide if we are able to resect or not the patient. So it's a matter of the surgical policy. It's a matter of the surgical attitude that we apply to our patient. Of course, they are aggressive. They propose surgery for many patients, and these are the results, which are very, very good. Speaking about staging, I would like to show you this paper. We as a surgeon, we like to use the classification proposed almost 50 years ago by Bismuth and Corlett. They divided, in 4 types the cholangio accordingly to the site of the disease. Later was proposed by Janaji and Blumgart the Memorial Sloan Kettering Cancer Classification, and they divided the staging in 3 T level accordingly to some items. But more recently, not really recently because April 2011, more than 10 years ago, there was this paper, very clear, very interesting to me, because they exactly focused their attention on many different items which must be considered when we see a patient with Klatskin tumors to understand if the disease is resectable or not. And this is something that the liver surgeon has to do, not the radiologist, not the oncologist, not the endoscopic guys, because we as a liver surgeon, we know the complexity of the anatomy, the complexity of the organ, and we are able to focus on very important details. In fact, the so-called BPA approach, meaning that we need to look at the bile, the porta, and the artery, all together, because all of these three, compartments should be clear of the tumor, meaning that we need to have a margin. We need to clear the vessel. So it's not enough to focus on the biliary involvements. We need to look at the porta. We need to look at the arteries. And as I said, it's important that the surgeon pay attention to these aspects. By the way, using this very common and important classification, we know that we can associate different resection according to the presentation. I'm used to ask to the radiologist or sometimes to the endoscopic guys to write down the classification according to the cholangiography, exactly defining the type of the biliary involvement. Most of the time, they are not able to give to us the exactly extension of the disease, but we as a surgeon, we know that we can perform a different operation according to the type of the cholangium. Oh, sorry. Can you see the presentation?
Almost.
It's working. I don't know what is going on. Okay, I stop the sharing. I try to do it again.
It's loading, but
it's loading. I don't know why. Probably it's a matter of the network. I don't know why. I don't know why. I'm sorry, guys. I try to. I stop the sharing and I do it again.
The PowerPoint file is in your computer or it's in the internet? In the server?
It's on the cloud. It's in the cloud.
Okay. Would it be possible to download in your computer or it's not possible?
Give me a second. Sorry, guys.
No worries. While waiting, maybe you can talk about the Italian pizza.
I try to use my laptop. I need to leave the meeting. Give me 2 minutes, okay?
Yeah, sure.
I'll be back soon.
Fabrizio.
Yes.
Ça va? We have Dr. Augustine as well, who is you met him last time, no?
Yes.
He's
Yes, I think so.
New medical oncologist. Hi, Dr. Augustine.
It's not easy.
Hi, Dr. Abdallah.
And thank you for the others who are here. Dr. Karim, Dr. Zaid, Dr. Ahiba. Dr. Ahiba is a gastroenterologist in private hospital. And we have Dr. Abdullah Rawahi as well.
Yes. Do you have some news about new drugs for cholangiocarcinoma or not?
Yes, but regarding regarding the new recommendation of the addition of immunotherapy as first line, durvalumab, but the benefit is not so high, so we haven't adopted yet as a standard practice in the center. So far, the median survival has only been increased by 1 month, so I think we need more data to recommend as first line.
Yes. And do you need, Augustine, do you need the histology to start the chemotherapy or not?
Yes, of course, yes.
Because sometimes it's not easy to have histology of this kind of cancer.
Yeah,
so
but
sometimes just with the brush, yes.
Yes, in the case of advanced disease, it should be easier than for localized or locally advanced. So, well, yes, we need histology, especially for target therapies. Sometimes we might consider replacing it by circulated tumor DNA or cell-free DNA, but always it's better to try to get tissue.
Yes, yes. But in some cases, not easy. I don't know if Matteo is, he found the slide now. I don't know.
No sound with Matthew.
There's maybe some controversy regarding if this is really necessary, the tissue, but usually we prefer to have histologic confirmation of the malignancy.
Yes.
I think it's the same for you also to proceed with so complicated surgeries. You need to be sure of.
No, so some we have some cases that it's very hard to have a histology. So after the MDT discussion, we decide to perform major resection, but we don't have the clear histology of the cancer. So last year we performed 22 resection for cholangiocarcinoma in our center, and finally we found 2 cases without cancer. So was a immuno was cholangitis, immunocholangitis.
Can you hear me?
Yes.
Yes, yes, yes.
Oh, okay, sorry guys. I don't know why the technology today doesn't help me.
No worries.
Hello, can you hear me?
Yes, yes.
We have Dr. Alwaris is joining as well.
Yes, with Dr. Alvarito from the
Royal Hospital.
From the Royal Hospital Liver Transplant Center.
I don't know why I don't have the sharing button to share my screen. I don't know what happened today.
Sorry, Abdullah. Sorry. Do you hear me?
Yes.
Maybe I have problem with the connection. Sorry, I was in the meeting. We just finished the transplant meeting, and
no problem.
Yes.
You are done with the presentations, or
no?
Not yet.
We have some problems, so we have just 25 slides, but we have 30 slides more. Yes.
Okay.
Yes.
Okay.
It's good for you to be there, because I think for a liver transplant center, it's very important sometime to discuss these difficult cases, and in some cases we have indication for a liver transplantation. Do you know in US they have the Mayo Clinic protocol? In France we have a transfield protocol for cholangiocarcinoma. Yes.
So guys, I'm back. Sorry.
Yeah.
We'll come back.
Do you see the presentation?
No.
Yes.
Now yes. Good.
So I was
25.
It's important to, sorry again, guys. It's important to note that when speaking about Katzkin tumor, it's important to remember the significance of segment 1, which we need to resect in any case. And this slide shows the anatomy. We know that, segment 1 is done by the Spigelian portion, which is the left side of segment 1, the paracaval portion, and the caudate process. And here you have the type of resection. And even if you do a standard right hepatectomy, in case of Katzkin tumor, we need to do this type of resection to remove all segment 1. This is suggested because the biliary anatomy of segment 1 can be very different. And even if the right side of the segment 1 should go to the right duct, or anyway to the posterior right duct, sometimes the anatomy is complex, and when removing the biliary the carrefour of the bile duct, it's important to remove also this part of the liver to reduce the risk of local recurrence due to the uncompleted tumor clearance. And speaking about the margins and the surgical margins, we should ask to ourselves sometimes, in case of more advanced disease, such as, for instance, type 4, which is the resection we should do, right or left trisectionectomy? And the kind of answer comes to the anatomy, because we know at the same time that the left hepatic duct, generally speaking, it's a little bit longer in comparison, of course, to the right or anyway to the right side of the bile duct. And this can be used surgically to achieve a zero margin. But at the same time, sometimes we need to use the right posterior duct, the B67, because usually is long enough to achieve a negative margin on the bile duct sides. Of course, we need to do the volumetry, but I will show you a case to better understand this situation. Another important aspect is about lymph nodes. This slide shows the classical classification by the Japanese Society of Biliary Surgery with all the stations. And in general, the standard lymphadenectomy
is on the grouping that the Japanese guys call as N1, which include station number 12 and station number 13. There is also the grouping number 2, which include the lymph nodes on the hepatic artery, station 8, but also some posterior lymph nodes, and also the so-called extended lymphadenectomy in the grouping N3, which include very, to me, distant lymph nodes, which should not be done as a standard lymphadenectomy. But why this is important? Because sometimes we make confusions, also as an expert, because you know, the American and I would say European classification is a little bit different from the Japan classification, because the Japanese guys, they classify the lymphadenectomy from dissection 0 to dissection 3 by identify the grouping of the lymph nodes, while the AJCC, so the standard TNM, they classify according to the number of the lymph nodes removed, independently by the localization of the lymph nodes. There is also another important aspect about the minimum number, because one side, the Japanese guys, they say that we should remove as much as lymph nodes, as much as possible in terms of number of lymph nodes. You know that the Japanese guys, they are very skilled, so they like to clear all the field and remove many different lymph nodes. On the other side, we have the American guys, the European guys, in which they, for this disease, the debate is a debate still today. And generally speaking, we consider that the minimum number of 6 lymph nodes that should be removed to have a good staging of the disease. It's important to understand the selection of this patient, because, you know, there is a long process in case of jaundice that brings this to multiple procedures before surgery. I quote this paper, the group of Makuchi, which together with the group of Nagoya, they are the most famous and the most skilled surgeons in performing this type of surgery. And they clearly propose a flow chart in which they say when to put the biliary drain and when to do a strategy of hypertrophization of the contralateral liver with a very high cutoff values. And only when the bilirubin is less than 2, they propose measure hepatectomy. This flow chart is very clear, is very important. It's not easy to follow, but it's important to say that this flow chart, which was reported in 2003, was the only one associated with no mortality for a disease that still today is associated with 5–10% of mortality in expert centers. In fact, I like to show you an overview of the results. The short-term results, meaning perioperative, as you can see, mortality, it can be up to 50%. In Europe, we are around 10%, but in Japan, less than 2%. And the mortality is associated, is due by, of course, liver failure, infective complication, and sometimes vascular complication, because sometimes this patient had also vascular resection because of the disease. While the long-term overview of the results, we can say that the 5-year overall survival, it's around 30%, and the 3-year disease-free survival is just 20%. So it's an aggressive disease. And the events associated with this survival are, of course, local recurrence, lymph node metastasis, and sometimes distant metastasis. It's important to know, again, in terms of survival, that the lymph nodes, they play an important role. You see how those Kaplan-Meier curves separate according to the negative and positive lymph node status. And also the importance of the positive of the grouping. And again, they are Japanese. So this is the Japanese grouping. It's not just the number of lymph nodes, meaning that those group of patients, they had lymph nodes in station 8 and 14 at least, which not always are clear in at least in Western countries. Also, the margin for Klatskin tumor is critical, because sometimes we cannot achieve R0 resection because of the infiltration down to the pancreas or up to the liver. But as you can see, there is a clear association with the survival. And I like to show you a case just to make you, better understand what we can do for this disease. This was a guy, 62 years old. He was a good patient. He is a good patient because he is alive. He just had the tonsillectomy in the past. He was admitted to our hospital because of obstructive jaundice. The total bilirubin was 14. And he had this MRI before placing of a drain, in which, as you can see, there is a biliary stenosis. I show you again. This is a T2 MRI in which you can see the biliary stenosis, which is typical of a Klatskin tumor. You can see the bile, duct dilation, which is mainly present in the left hemiliver, which indirectly suggests a little bit more, involvement of the left side of the liver. So we did a tumor and technical board, because this disease is very sophisticated, and we as a surgeon has to think about what to do. And the diagnosis of a Klatskin tumor type 3 or 4 with B6-7 free of disease was placed. The patient was considered to be fit for major surgery. We did a lot of counseling to him, because, the process that, as I said before, the process before surgery can be quite long. So the patient and the family has to understand all the steps that are required to bring this patient to the operating room. We decided to do a percutaneous approach and to place a PTBD in B6. And then we did a liver volumetric analysis. And this was a CT scan, which, of course, was done. And this patient had also a kind of anatomy which is in favor of proposing a left trisectionectomy, because he had, the P6-7, which that was separated to the P5-8. And, of course, symmetrically, the two arteries, the artery for 5-8 and 6-7, they were separate. And it's important to look at these arteries when performing this type of surgery, because, of course, if you do a left trisectionectomy, this patient will have at the hand one artery, one portal vein, and one hepatic vein. So all these three vascular compartments has to be respected to minimize the possibility of complications. We did a volumetry, and by using one of the available software to do the classical volumetric analysis, and the remaining liver, the segment 6 and 7, was 42%. And so we did this procedure. We decided to do left trisectionectomy with hilar lymphadenectomy, common by direct resection with the reconstruction. I did the respiratory laparoscopy, which was negative, so we did the laparotomy. And I found a very small lesion in segment 6, which was this one, which was a little bit hard. I did also a contrast ultrasound here, and I found this type of finding. I removed the lesion. I did a frozen section that was negative. So I studied the patient with ultrasound during the laparotomy. These slides show the typical appearance of the drain in the bile duct. And this was the appearance of the tumor. this one, with the left bile duct, B58 and B67 separated by the tumor, which, as you see, it's not easy to see because the echogenicity of the tumor, it's just a little bit lower in comparison to the normal liver. And so the liver was completely immobilized with the section of the ligaments. Of course, the hepatic pedicle was dissected and all the vessel was taped, meaning the left hepatic artery, which was an accessory, the common hepatic artery, then the left, the right, which was from the superior mesenteric artery, the main portal vein, P67, P58, the P left, and then the two arteries for the right hemiliver, and of course, the common bile duct. Then the segment 1 was completely mobilized by the cava. Then we moved to the section of the common bile duct. We did the frozen section that was negative, and then, you know, simultaneously to the dissection of the pedicles, we did the lymph node dissection in station number 8, 12, and 13. This was the finding. You know, you have the hilum preparated with all the taping of the vessel. The bile duct was already sectioned, and you have, of course, the two arteries for the right hemiliver, and the veins, the portal veins. Then I studied the precise, you know, inflow of the liver to understand exactly, you know, which was the artery for the sector 5-8 versus the posterior right sector. And this is something important, very easy to do, because sometimes, you know, the anatomy can be tricky. And so it's important to use the ultrasound to be sure that you can ligate a vessel rather than spare another vessel, because otherwise can be very complicated. And so by using the intraoperative ultrasound with the Doppler, you can identify precisely the pedicles that you can ligate. And in this sense, we got the demarcation line. You see, you know, 6-7 versus 5-8 plus the left hemiliver. This it was the point of the insertion of the PTPD. I'm to put a finger of the glove to minimize the leak of the bile, and also to make you know, something more clear. We did the ICG fluorescence to understand better the visualization of the demarcation line, which was anyway visible just because of the clamping. And then we did the transaction by using Kelly laser or some type of energy device. And this was the finding at the end. Of course, we can check the proper, you know, vascularization during or after the resection, and this was the final finding in terms of intraoperative ultrasound. So I'm used to study, you know, all the inflow and outflow of the liver, in particular in such complex cases in which, as I said before, you have just one hepatic vein, one artery, and one portal vein. So the operation was quite long, 10 hours, sprinkle time 1 hour, blood loss 300 milliliters, and no blood transfusion, and 1 overnight in IC unit. And this was the final appearance of the liver, with after, you know, the complete dissection of the pedicule, of the inferior vena cava, the transection line of the common trunk, and the right hepatic vein exposed to the cut surface. And of course, I placed a classical biliary jejunostomy with the PTBD inside, and this was the final aspect of the liver after the resection, with the macroscopic appearance of the biliary stenosis. And I move to the conclusion of the presentation and just show you this flow chart, which is taken from a consensus published on Nature Review. And as you can see, the first step is this question: is disease resectable? Yes or no? And you see the difference in survival between the two categories. But what is important to me, and I like to remember, is that this part should be done by us as a liver surgeon. And it's important to stress the fact that the surgeon attitude may impact the prognosis. So in summary, hepatectomy is indicated for curative resection of perihilar cholangio. Yearly consultation of a dedicated HPB surgeon is mandatory. The strategy should be based on preparative imaging and intraoperative findings. Biliary drainage according to the type, and should be decided in a multidisciplinary setting. Resection of segment 1 in any case, and also lymphadenectomy in any case. And what about the future? To me, more surgery to increase the resection rate, because as I said, the surgeons dictate the outcome. Probably we need to work a little bit more on the molecular profiling to select the best candidate. But there are some interesting research areas, such as downstaging procedure before surgery, and also adjuvant therapy to prevent recurrence. And of course, there is the important chapter of transplantation, which is nowadays performed for hilar cholangio, both in or without research protocols. Thank you very much for the attention and invitation.
Thank you, Matthew. It was so nice and so interesting talk. And,
sorry, guys, for the technological problems before.
No worries, no worries. And yeah, in fact, it's not the case of perihilar cholangiocarcinoma is always, I would say, case by case. Each case is, I would say, different from the other. And it's not a straightforward, I would say, management. I
no,
don't
exactly.
think, yeah. Somebody has any question?
Excuse me?
Yes, better.
Yes, مساء الخير. Hello, Professor. I had a question about liver transplantation. If you could remind us of the setting. When is it indicated, for which patient, and in this case, was it indicated maybe in a research protocol?
See, to be honest, I'm not doing liver transplantation, so probably Professor Panaro should be the guy that can answer better than me. I have to say that nowadays, at least in Italy, the liver transplantation is reserved for those patients that are not considered resectable. So again, to me, it's important to say that the definition of resectability, as you said before, it's not a standard statement, because it's dependent by the ability, capability, and I would say about the possibility of the surgeon. But if the patient, cannot be resected, for sure, liver transplantation should be the least considered, because the results are good. As you probably know, there is the famous Mayo protocol proposed many years ago for Klatskin tumor. And recently I participated in a meeting on this topic, and in Italy we do liver transplantation for some patients with Klatskin tumor by using a different approach, not exactly that was proposed by Mayo, but can be an option. Fabrizio, what do you think?
Yes, I think that if is a good indication, but there are different protocols in US Mayo Clinic protocol, in France Transfield protocol. If we selected a good case, we have good result. The same for the liver metastasis for ACC. I have another question. What about the segment 4 for cholangiocarcinoma? We need, for example, for a 3A cholangiocarcinoma, we need to remove the segment 4 or not? This is, I think it's not easy to answer this question, because in sometimes we have a difficult to grow the future remnant liver. And the second question, what do you think is for you is the best procedure to optimize the future remnant liver in case of cholangiocarcinoma?
Yes, thank you. Important questions. Segment 4. If you look at the experience mainly from North America, in most of the cases, they propose right trisectionectomy, meaning the removal of the right liver plus segment 4, so leaving 2-3. And they propose almost the standard approach by using this operation. This is what I saw when I was in MD Anderson in Houston many years ago. And they use the PVE of the right hemiliver, and they also embolize the branches for segment 4. So they do a PVE extended to segment 4 to increase the hypertrophy of segment 2 and segment 3. If you look at the Far East, Hong Kong and Japan experience, they have an approach, the different approach, mainly based on the presentation of almost case by case. So they do not propose a systematic approach, meaning the extended right hepatectomy or the extended left hepatectomy. For instance, to answer to your question, Makuchi, he was used to say that you don't need to remove, if you do an extended right hepatectomy, you can leave segment 4 superior. You need just to remove the segment 4 inferior. So, and this can help in terms of leaving a little bit more liver remnant, you know. And I think it's reasonable, and it's reasonable also to decide the type of surgery based on the biliary presentation, not to do a one operation for whole. And we know that this is a matter of mentality, because in North America, they learn to do an extended right by passing through the falciform ligaments, and they, you know, divide the liver vertically on that line, and this is what they propose. In Japan, they have, as I said, an approach based on the type of the presentation. Speaking about the hypertrophy of the liver, I think that probably for biliary tumor, ALPS approach should not be done, because the mortality has been shown to be very high for this disease. So PVE should be the first choice. Of course, together or not, we can discuss with you, because you are a master on this, with the hepatic vein embolization. In my experience, I did some cases of PVE, and one PVE was not enough. We applied also the hepatic vein embolization. So we do not do usually together PVE plus hepatic vein embolization. This is a matter of experience and abilities of the radiologist, basically, rather than other issues.
Thank you. I have a question regarding a new adjuvant treatment. I would say, how feasible is it, especially for case, for example, where we are suspecting lymph node metastasis, or for example, there are suspicions of arterial involvements, like common hepatic artery, it could be involved by the tumor. In such case, maybe, I don't know, there is discussion for new adjuvant treatment and then re-evaluation. I'm not sure how feasible is that, and especially for patients who had biliary drainage complications with cholangitis, liver abscess. We need to optimize the future liver remnant, giving new adjuvant treatment in such cases. I don't know how feasible is that.
Unfortunately, it's not really feasible. I mean, it's a chapter in which we need to work together with the oncologists to try to understand if there is a room for neoadjuvant treatment. But I don't think so, because this patient, in most of the case, because of the jaundice, they are not really fit to do a lot of treatment without placing definitive stents or other procedures that in most of the cases those procedures make the patient anyway unresectable, because they go into different procedures that rarely they can come back and become fit for surgery. You mentioned the artery infiltration. I believe that even if Fabrizio, who does liver transplantation and is skilled to perform arterial resection and reconstruction, I don't think it's a good indication. Of course, can be done technically, but when there is a kind of advanced disease, the prognosis is very bad. We should work a little bit more, I have to say, with the adjuvant treatment. As you probably know, nowadays the oncologists propose capecitabine to all the patients after surgery, independently by the type of tumors, because they consider biliary tract tumors a single category made by gallbladder, extrahepatic, distal cholangio, intrahepatic cholangio, N0, N1, N2, R1, R0. I mean, they make a mix, and they propose, based on only one study, capecitabine for 6 months. I think this is not enough. I think it's not a good point, because if you do radical surgery, R0, with no lymph nodes, 6 months of capecitabine, it's not very important. Otherwise, if you have a patient and you do sophisticated surgery with anyway R0, but with lymph nodes, they should invest a little bit more and do more chemotherapy, more significant chemotherapy for those patients.
Yeah, I agree. Also, we have recently the long-term outcome of PILCAB study.
Yeah,
it shows again the benefits of adjuvant capecitabine. But as you said, maybe we need to take it case by case, lymph node positive, lymph node negative, and take it from there. I don't know what Dr. Augustine think about it as well.
Actually, the benefit was seen in an per protocol analysis, not an intention to treat. There was no overall survival benefit for the whole population. And regarding to the neoadjuvant treatment, one of the problems is the low response rate. If the patient is marginal resectable or unresectable, only one quarter of the patient responds to the combined chemotherapy. So that's the difference maybe with the combination chemotherapy for, let's say, colorectal liver mets, when you have maybe 75% of patients may reach a response, partial response. So here is that the problem that is the low response rate for treatment. That's why it's not now is still considered experimental neoadjuvant treatment for biliary tract cancers.
Yeah, the operability window, temporal window, is very close in this patient. So if the patient can have a chance to be resected, exactly, we like to resect them. So probably the borderline resectable for Klatskin tumor does not exist. I mean, can be, but it's one case. I mean, so yeah. If they are resectable, they should go to resection, or a few of them to liver transplantation. Otherwise, they go for systemic therapy or radiotherapy, but they cannot come back to become resectable.
Exactly. Thank you. We have a question from Dr. Hiba, who is a gastroenterologist in one of the private hospitals here. She's asking if you have different choices for drainage, biliary drainage, which type of drainage would you prefer in resectable cases? she means while, for example, patients on neoadjuvant therapy or patients who have like very high bilirubin?
Well, it's important to decide if the patient is resectable or not. If the patient is resectable, I prefer percutaneous approach because I work with my radiologist and I decide with him or with her the bile duct in which I would like to put the drain. And in my experience, the interventional radiologists, they are a little bit more skilled to put the drain in B6 versus B7 rather than B8 versus B5, or even B2 versus B3. In comparison with the endoscopic guys, because from below, they have difficulties to understand the anatomy. And I know very, very skilled endoscopic guys. There is one who works in Milano that is very, very, very famous and very skilled. And they can navigate endoscopically in the liver and reach the very peripheral duct. But generally speaking, with the ERCP, the standard endoscopic guy, they have difficulty and they put the drain most of the time in the left or in the anterior duct, and sometimes without know where they are exactly. And if the patient needs an operation, you need to decide, the laterality of the disease, and so which is the part of the liver you need to spare versus to resect. And of course, it's usually the drain should be placed in the liver that remains, not in the liver that goes away. So that can be an answer. Ideally, the PTBD should not be placed down to the duodenum to reduce the risk of cholangitis because of the infection. But in the real world, it's not easy because sometimes if you don't put the PTBD down to the duodenum, there is an increased risk of displacement of the drain. So also this should be decided case by case.
Yeah, clear. Thank you very much, Matthew, for your time and for
thank you
being us with here. I think we will end here. I don't know, what do you think, Fabrizio?
No, excellent presentation as usual, and very good school of hepatic surgery. So thank you again, and we organize for next January another HPB Cafe with the Professor Troisi. You are invited to discuss about robotic surgery in HPB patients.
Wonderful.
Yes,
I will be with you guys.
Yes, we are trying to organize a meeting in Oman as soon as possible. So we are trying to organize and invite you for a lecture.
All right. Thank you. Thank you very much for the opportunity. Sorry for before, and keep in touch, guys.
Okay. Bye.
Thank you, everybody.